I hope everyone can see him.
Hi.
He is going to be the expert at the hub with us, and he is also going to present a couple of ECGs, interesting ECGs. So this time we are deviating from the usual format of these meetings, which is basically a case and problem solving platform where people are presenting any problem issues, and we are taking it up for a discussion amongst all of us, followed by a small presentation at the end. This time we thought that being cardiology oriented, how can we do without ECGs? So Dr. Seema, who is a practicing physician, very active and very academically oriented, and I must compliment her. I once attended a meeting where she had done phenomenal amount of research on COVID-19, on the SARS-2 virus, and she was very informed about it. So she has wanted to present what was called as killer ECGs which apparently might look normal or innocuous to us, but unless we examine them carefully, we might be missing some conditions which might be threatening to life or might be a very serious condition. So with that in mind, we are kicking off this session. It's going to be a very, very interesting session. So welcome everyone to join. And like Prashant said, please put on your videos, please offer any comments. And this is free-flowing discussion where everyone is welcome to participate. No one is right or wrong. And we will all benefit and all learn from the session. Once Dr. Seema finishes, then my colleague, Dr. Sadhir, who's also here, he's also brought a couple of interesting ECGs, which also will be presented. So this is going to be an ECG intensive, not basics, but what are we actually see in our clinical practice. So over to Dr. Seema to take the presentation forward.
Thank you very much, sir. Thank you for the kind words. And I'm going to share screen now. The slide is not moving.
Dr. Seema, you just have to click on the presentation once, and then it will start moving.
Okay. So today our topic is, good evening friends. Today our topic is killer ECGs. Killer because they may not look sinister, but they are. Okay. And I'm deviating away from STEMIs that we usually come across. So it is something else. So this is our first ECG. Now 70-year female presents with extreme weakness to the casualty and past history of carcinoma lung with metastasis. Now, if you look at the ECG carefully, it looks okay. But what is the abnormality that jumps out at us and tells us that there is some emergency? Can anybody guess?
Yeah.
I'll give you 10-15 seconds.
Yeah, anyone would like to comment, please go ahead. Many people are quite diffident in commenting on ECGs, so it's all right. If no one comments, Dr. Seema, you have to reveal the secret to us.
Yeah. So, but if you see, everything is okay, you know, heart rate, rhythm, everything is okay. But you look carefully at the QT interval. Okay, so QT interval is short. How do we measure QT? My arrow is visible. So we measure from the beginning of the QRS to the end of the T wave. QT means it's a complete depolarization of the ventricle and repolarization of the ventricle. Roughly normal QT interval is, this is the RR interval. So QT interval should be just less than the half of the RR interval. So it should be somewhere here. But if we look at this QT, it is looking very short. Okay, so this is a case of short QT interval. So I will just go through some definitions. Now here it is written QTC. Now what is QTC? QTC means corrected for the heart rate. C stands for corrected for the heart rate. Because QT interval varies with the heart rate. It is inversely proportional to the heart rate. So to avoid that confusion, we take corrected QTC for standardization, and it is corrected to the heart rate of 60 beats, and this is corrected by formulas. Okay, so normal QTC is you can remember just a rough figure of 400. So normal QTC is 400 plus minus 30. So if we calculate by boxes, small boxes, the QT interval roughly in clinical practice is around 10 boxes or 9 to 11 boxes, then we are okay with it. Or if it is just half of RR interval or less than half, we are okay with it. Long QTC is
Many of
clearly
the
defined.
newer ECG machines,
Huh?
many of the newer ECG machines automatically calculate the QT and QTC
Yeah, yeah,
along with all the other
yeah,
intervals. So
yeah.
that might be a
But
useful investment to buy, spend some more money and buy a ECG machine which calculates all these. But
yes,
otherwise, you can use these forms.
yes. Long QTC is defined. And you remember this number 500. 500 is dangerous. But for male and female, little bit there is a difference because in female, the QTC is little longer. So the cutoff is 460, 440, but you remember this figure of 500, which is dangerous. But short QTC, let me tell you, there are no clear-cut cutoff criteria for short QTC. But roughly for all practical purposes, be it male or female, we would like to take is at 350. Okay. So in this case, I calculated it was small 7 boxes and QTC came out to be around 340. So less than 350, it is a short QTC interval. Now you go back to the history. History was of carcinoma and metastasis, which is a very common cause of short QTC, and the condition will be hypercalcemia. See, in clinical practice, hypercalcemia and digitoxicity, these are the most two important causes of short QT. And digitoxicity, patient will give history of digoxin. So what we are left is with only hypercalcemia. So whenever patient of metastasis, some malignancies, we see short QT, we should be taking it not lightly. Okay. Now, congenital short QT is very rare, very, very rare. Hardly 100 patients might have been described in the literature. So, for all practical purposes, we'll be coming across hypercalcemia and digitoxicity. There are other causes as mentioned below, but see for
One
them.
of the common reasons now that we are seeing hypercalcemia is actually vitamin D intoxication.
Yes.
Because vitamin D has become a fashion for patients to ask and for physicians, all of us, to prescribe. And I have seen at least a couple of cases with severe hypercalcemia caused by therapeutic vitamin D, prescription, and patients developing this.
Okay. Now, this is, so here I have written ST elevation. So hypercalcemia, when it causes short QTC, it is associated with ST elevation. That is another point. And if digitoxicity causes short QT, it will be associated with ST depression. Okay, so this is the differentiating point. Now to highlight that point, this is another case of hypercalcemia, where you can see clearly this is short QT, but you can see slight J point elevation, ST elevation in V2, V3, V4, V5, multiple leads in AVL. So this is how ST elevation will be present in hypercalcemia. Here the calcium was more than 15, so it was a medical emergency. Okay.
Just
Now
1 second before you go to the next slide. Before you go to the next slide, just go back. Would anyone like to make any comments on hypercalcemia and short QT intervals? Anything? Any points? Any other points that we may have left out, or would anyone like to raise any queries? Please go ahead. You can even put it in the chat, or you can just speak up. I thought these were very, very interesting ECGs that Dr. Seema had brought, and very important points which we might otherwise miss. And the point about ST elevation as in hypercalcemia and ST depression and digoxin causing short QTC, again, very interesting. So,
and there is one more point. Many a times hypercalcemia causes J wave, prominent J wave. J wave is a junctional wave. Where it is present, this is a QR and this is ST segment. So it is present at the junction of the QRS and ST. There will be a J wave present. This is also a feature of hypercalcemia. Okay. Now this is a case sent to me by a colleague. 50-year male, chest pain and palpitation. This is the history. And this is the ECG broad complex. All right. The heart rate is around 114. If I give you the history, you will pick up the clue and you will tell the diagnosis very fast. But right now, I want audience to answer this. What do they think? Is it VT or is it not VT? Or is it something else? Anybody can take a call. Heart rate is around 114, BP is 100/60, oxygen saturation is normal. Patient has presented with chest pain and palpitation, and there is a very important history which I am holding for a time being. So our time is up. I think 15 seconds. Somebody wants to answer?
1 second.
Yes.
I think let Dr. Sabir analyze the ECG a little bit.
Yeah, in this particular ECG, there are 2-3 very glaring things. The first is the ST elevation in AVR, and the second is broad QRS. You can see little bit traces of P wave in between. It's look like that it's a AV dissociation kind of thing with broad QRS, regular QRS with AV dissociation, ST elevation in AVR. By definition, it fits into slow VT.
Yeah. So now I give you the clue.
So definitely one of the important differential diagnosis will be slow VT.
Okay. So now would you like to consider again your diagnosis, sir? CKD. Patient is of CKD. I go back.
I think someone in the chat is put up some comments. We can look at that. In the chat, there are some comments. People have answered the questions.
Okay. Anybody answered hyperkalemia? Because this is hyperkalemia.
So like Dr. Alpana Chugh has said hyperkalemia. Let's ask her why she felt it was hyperkalemia.
Fantastic, Dr. Alpana.
So Dr. Alpana, can you come in and just tell us the reasons why you felt this was?
Like the pattern is like sine wave Q pattern. It's evolving into that and tall T waves, very tall T waves.
Yes.
And the sine wave Q pattern.
Yeah.
Broad QRS with sine Q wave pattern.
So it's a good point, but let me tell you that by the time the patient reaches sine wave pattern, there is usually bradycardia, there are some blocks. So it is somewhat misleading when we get a wide QRS with a heart rate of more than 100 and around 114 and this kind of a presentation. So I think making a diagnosis of slow VT is very much on the cards, and rather we must look at the clinical circumstances of the patient before we commit. But just looking at the ECG, slow VT is a very good differential diagnosis.
Okay, so now what are the points which are in favor of hyperkalemia? I should say definitely there's a tall, tented P, and my terminology is pinched P wave. See, if you pinch your nose like this, so it becomes like this, you know, P wave at the top. It's a very classical of hyperkalemia, narrow base, pinched at the top, but it is called tall, tented peak T waves, which are very much visible here, 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 here. Number two, this is very, of course, slow heart rate, but you said it is slow VT, so I'll take it, but otherwise slow for VT. Secondly, the AVR is quite broad R wave and tall R wave. This is a sign of sodium channel poison, and hyperkalemia is a sodium channel poison. So tall and broad R wave, it is a CKD. What we do is we give calcium gluconate. We don't think it is VT or not. So what is happening here? Am I audible?
Yes, yes, very much
Okay.
so. We are fascinated.
Now you see with calcium gluconate, the whole picture is miraculously changed. So when you give calcium gluconate to a case of hyperkalemia, right in front of your eyes, the changes will start disappearing. And if you think it is VT and you give amiodarone to such cases, amiodarone is a sodium channel blocker. So you may kill the patient. So in a case of CKD, think it as hyperkalemia. There is no harm in giving calcium gluconate in a VT case, but it will definitely benefit in a hyperkalemia case. But if you give amiodarone on the contrary, then you are in for a trouble. So this was hyperkalemia.
So I want to comment one more thing on
Yes,
this,
sir.
that if you see the first ECG, the broad QRS, in precordial leads, it is concordant. You can go back to that ECG.
Yes.
Can you
Yeah,
go
this
back?
is the ECG, sir. This is the ECG.
Yeah.
And
If you see,
actually,
there is
yeah,
no R wave in precordial leads.
yes,
So it's
sir.
a concordant QRS pattern, which
Yes,
again goes in favor of VT. And now
yes,
you see the next ECG.
yeah.
Here in V5, V6, there
Yes, it
is
has become upright.
definitely an R wave. So
Hmm.
the axis has changed. Again, that point goes in favor of VT.
Yes. This
So
is how it
sometimes
all,
it is quite difficult
yes.
to make out what
Yeah.
could be
Yeah,
the
it is
clinical
difficult. Yes.
situation.
But the purpose was to tell that in hyperkalemia, in a dialysis patient, in a CKD patient, better to give calcium gluconate and see what's happening.
Okay,
If the
okay, Dr.
patient
Seema,
is,
Dr. Seema, now I think everyone can identify what this ECG is.
yeah,
Is there anyone who can we have people writing in the chat what is this ECG, or anyone can speak out? Is there any doubt about this ECG? Anyone would like to comment on this ECG in the chat? What is the diagnosis of this ECG?
should I go ahead, sir?
Yeah, go ahead.
So this is again the same thing that I told you, tall, tented and peak T waves, like pinch T waves till the top. So this is typical of hyperkalemia. The T wave changes appear early in hyperkalemia. As soon as the potassium starts rising above 5 to 5.5, the changes start appearing. What are the other changes? Remember 4 B's, which are very important. Bradycardia, blocks. Blocks means AV blocks, all kinds of blocks, first degree, second degree, complete heart block, broad QRS, and bizarre. Bizarre means it will not fit into any bundle branch morphology. It will be very weird, bizarre QRS complex. So these 4B, patient can present, like supposing a patient is hypertensive on ACE inhibitors and suddenly presents with bradycardia, a new bradycardia, you should think of hyperkalemia. Then next is tall tented T waves. Now it's a great mimicker. It can mimic like VT, which we saw earlier. It can mimic like STEMI also, ST elevation, myocardial infarction. Then potassium causes atrial paralysis. So the P wave will become flat and eventually they will disappear. And when P wave disappears, the QRS widens, so it becomes a sine wave. So that is very terminal in hyperkalemia. Now this is a case of hyperkalemia. I have just put this slide up to show that this is an RBB morphology. T waves are inverted because of the secondary to RBB. Now inverted T waves also, you can see that there is a peaking of the T wave. So T wave peaking does not mean it's only an upright T wave. So you have to appreciate it in inverted T waves also. This is one
So
more
I think
case of,
very good points, very good points about hyperkalemia. Can you go back? Can you go back, please? Can you
this
go
one?
back? No, back to, yes. Looking at this. So this is a great mimic. It can mimic various conditions. And I think the point that was highlighted by the first ECG was that in a situation where you're not sure whether this is VT or not, and the patient could be having hyperkalemia, under each and every circumstance, try to give calcium gluconate, which is harmless in every situation. But giving amiodarone in hyperkalemia might prove disastrous. So I think that's a very good learning point for all of us, that how we should approach a suspected case which might be hyperkalemia. Hyperkalemia can have so many manifestations, as Dr. Seema has pointed out. Unless we are aware or we suspect, we can miss it, or it may mimic some other condition.
and even this, the inverted T waves also can be peaked, that we should keep in mind. Now again, as I said, it's a great mimicker. See, this is a case of hyperkalemia, but the computer says it is STEMI, ST elevation. Why? because you can see that there is ST elevation in V1, in V2, and in AVR. Okay. But now what are the points which favor hyperkalemia? These are exactly the same points. The ST elevation in right-sided leads. V1, V2, AVR are mostly right-sided leads. So ST elevation confined to right-sided leads favors hyperkalemia. Then there is an arrow. This is a right axis deviation, rightward. Deep S wave in lead 1 means there is rightward axis. This favors hyperkalemia. And of course, our T waves tall and tented, which you can see in V4, V5. This favors hyperkalemia. So this was a case of, again, hyperkalemia, but mimicking STEMI. So at this point, I would like to differentiate between a right axis deviation in acute condition and in chronic condition. So what are the causes of right axis deviation in ECG in acute conditions? Suppose a patient comes to you with breathlessness, chest pain, oxygen saturation is little on the lower side, say in 80s. He brings a old ECG which is normal, and the new ECG is showing rightward axis deviation. The first thing that should come to our mind is pulmonary embolism. So pulmonary embolism is very important cause of acute right axis deviation. Secondly,
Dr. Seema, there is a question. Does hyperkalemia cause ECG changes in each and every case, in each and every patient?
No, not necessarily at all. Not necessarily. There is nothing 100% in medicine. In fact, we say waves are tall in early cases. They may not appear in early cases. There will be just bradycardia also. So nothing is no. The answer is no.
So we get a lot of patients of CKD who come to us with hyperkalemia with complete heart block, and sometimes you have a patient, you might get a complete AV block with a potassium of 5.6 or 5.7, and there are patients who you have put on, say, ACE inhibitors and aldosterone antagonists, and who come to you in the OPD with a potassium of 7 and completely asymptomatic and normal.
Yeah.
So it is not, earlier we were taught that the ECG changes mimic the potassium levels in the blood, and there is a progression of the ECG changes. That is correct. The ECG changes do progress from going from tall tented T waves to widening of the QRS to diminution of the P wave, and then finally the AV blocks, and then finally the sine wave. But this is not correlated with the serum potassium in all cases. So the answer is that it does not cause, and you have to, you cannot rely. But if you get the ECG changes, yes, you are likely to find hyperkalemia. But do not be fooled that this is only 5.6 and you can find sine wave also. It does not directly correlate.
So
I hope that answers your question, Dr. Shubham. Dr. Shubham, I hope that answers your question. Is there anything else you'd like to ask? Okay. Now, a question is, suppose you have a patient with hyperkalemia and hypercalcemia. How is that going to affect? That means one is shortening the QT and the other is producing prolongation of the QRS. So does hypercalcemia with hyperkalemia, will it have any effect?
No, I don't think so. Not much actually. And in mixed electrolytes, it is always very difficult. In fact, today only I saw patients that he had clinically swastic sign, typical hypocalcemia, and I gave calcium. He responded. His ECG also came better. There was a U wave. Initially, I thought so much of little ST depression with U wave. I thought it was hypokalemia. But when we put the BP instrument for taking BP, there was a swastic sign. So I gave calcium. He responded. Potassium also came low, but calcium was normal. So I don't know the cause.
So,
and
Dr.
ECG
Ramya,
also
so Dr. Ramya, any reason why you asked this particular question? Did you come across a case like this, or did you did such a situation arise for you, or it just crossed your mind because of the presentation? Yeah, Dr. Ramya, you can speak. No one here is going to.
okay.
No, sir. I just got it out while listening to the presentation. That's
Okay. So I think, like Dr. Seema said, that mixed
Now
electrolytes, it will be what is going to be the predominant effect on the ionic channels, which might dictate how the ECG changes.
Yes.
All right,
So,
we're back to your slide.
what is the acute right axis deviation, pulmonary embolism, hyperkalemia, and tricyclic antidepressant toxicity? Now, mind you, we will be seeing more and more these toxicity cases. I'm quite sure depression is really going to be high. So even tricyclic antidepressant is a sodium channel poison. So both of them produce a tall R wave in AVR, and both of them produce hyperkalemia and TCA toxicity. Both of them produce right axis deviation. Of course, arm lead reversal should be kept in mind. And then acute MI. See, I wrote acute MI first, but I spoke very last. Because in acute MI, right axis deviation is very unlikely unless the patient has an acute lateral wall myocardial infarction or posterior fascicular block. But then posterior fascicular block doesn't get, it does not get blocked so easily because it is a dual blood supply. Now, what is the cause of chronic right axis deviation? So all chronic pulmonary hypertensive cases will have a chronic right axis deviation such as COPD, etc. And all lateral wall MI, because the Q wave will form in one NAVL. So in one Q wave, so it will look like a right axis, it will give a right axis deviation. And of course, dextrocardia will have a chronically right axis deviation.
So I think in the context of killer ECGs, definitely pulmonary embolism, the great again mimic, and the great thing that we might miss is very important. And another useful point you have said is tricyclic antidepressant toxicity, which, like you said, I was speaking to a psychiatrist. He said that there is a pandemic of COVID and there's an epidemic of mental health issues. So we might well be seeing a lot of these kind of patients also. So it's a good point for us to keep in the back of our minds.
Now, this is back-to-back 2 slides I'm showing because the condition will be the same. So patient is 45-year male presenting with weakness. Anybody would like to take this? Or should I go ahead? This is one
in the
ECG.
chat section, you can answer in the chat also, or anyone can comment on the ECG.
Okay, I'll just hint at the camel hump appearance of the T wave here. Can you see in V2
maybe
and
Dr.
V3?
Sadbir? Maybe Dr. Sadbir can help us out in this case. Would you let us?
45-year male with weakness.
45-year-old male with weakness. So Dr. Sadbir, would you like to comment on the ECG and then reach the diagnosis?
Hypocalcemia.
Hypocalcemia, okay. And any other thing? So I think we have some comments in the chat. Again, we have some answers over here. Dr. Alpana, again, will you please come in and tell us what do you think and what are tip complexes? Dr. Alpana, would you like to?
She has muted herself.
Yeah, so we're trying to get her to unmute. Okay, Dr. Yasmin thinks this is WPW syndrome because I think, yes, come in, Dr. Alpana.
Hello, I'm not able to hear your voice.
Okay, we can hear you. Prashant, can you come in and just let us know? Is it better now? Can you hear us?
Dr. Alpana, can you hear us?
Okay, I think if Dr. Alpana, we can't hear Dr. Alpana. Maybe Dr. Ramya?
Sir, T waves are flatted, sir, and a prominent U wave is seen. With looks like apparent QT prolongation, but actually it's the U wave which is causing a QU interval is looking long. So this is a case of hypokalemia, sir.
Bingo.
Bingo, says Dr. Seema. All right.
Yes.
So Dr. Yasmin felt that this is WPW. Dr. Yasmin, in WPW, I think you just felt that because there was maybe a short PR, but classically on the ECG should have a delta wave, which is a slurring of the upslope of the QRS, which is not seen in this. So I don't think.
And broad QRS.
Yeah. And yeah, so that should lead to a slurring and the QRS widening, which is not seen in this case. So this you should not be diagnosing WPW in this case. Okay, next.
So this is this one is a camel hump appearance of hypokalemia. This is a U wave bumping into the T wave, and U wave is so big. Normally U wave should be 25% or less of the T wave. It is all slightly bigger than the T wave. T wave has become smaller. Okay. This is another case of hypokalemia only. Here you can see there's little depression. T wave is inverted because ST depression is also there. And what you see here is a P wave, U wave. So ST, now you see the history is very important. Patient has come with weakness. Suppose patient comes with chest pain, now you'll be confused whether this is ischemia or this is hypokalemia, because ischemia and hypokalemia sometimes look very similar. So in ischemia, if it's supposing you consider it as a T wave hole, so there will be biphasic T wave. But in ischemia, the second component should be negative. That means it should be going up and then down. Whereas in hypokalemia, it is first going down and then up. So because this up portion is the U wave. So there is a pseudo QT prolongation, QU prolongation, I should say. And why this is important? Because even this can lead to dangerous torsades de pointes, ventricular arrhythmia. So it should be treated. So this was all the features of hypokalemia here. There was sinus
Yeah.
There was sinus bradycardia. T wave were flat.
Yeah.
Eventually, in second case, were inverted. There was ST sagging. There were prominent U
Yeah.
wave in V2 and
so
V3.
Yeah. So this appears to be more, classical of hypokalemia and easier to diagnose in this ECG than the previous ECG. Now, let me tell you, we find hypokalemia very, very sinister problem in patients with heart failure, whom we are giving a lot of diuretics to. And many of these patients die because of ventricular arrhythmias produced or precipitated by hypokalemia. So it's very important for us to be able to recognize this condition early. And these ECG signs are quite subtle, as you can make out. So it's important for us to look for these in patients with severe heart failure who may suddenly die or develop a malignant ventricular as a consequence.
And pseudo QT prolongation in itself is something which is to be looked into. Otherwise, one may change the dose of drugs on the basis of that this is QT only. So
Yes.
Yeah. So, especially in COVID times, QT has become a very big issue with HCQS use. So pseudo QT prolongation, hypokalemia, and so we need to be aware of this and look for it active. Yes, next, Dr. Seema, please.
Now 70-year male presenting with atypical chest pain. So anybody would like to comment?
We have very bright people who are picking up these certain ECG changes very quickly, I must say. When I went through this presentation, Dr. Seema, she had to tell me, yeah. So full marks to all our participants who are doing very well. So come on now, look at V4, which is very prominent. V4, V5, the changes are very prominent. You can also see in the long lead 2 what is going on over here.
Anybody, sir,
Anyone?
answering, or should I go ahead?
Okay, so we have Dr. Alpana. I wish her audio was good. Okay, so we have some answers. Anterolateral ischemia, and I think a short answer was Ramya says, so anterolateral ischemia, QRS alternance, and short ST. Is there such an entity as short ST?
Not aware of.
Yeah. So Saksham says electrical alternance. So Saksham, can you come in, please?
Perfect.
And give us your comment as to why, what do you think this is? and what could be the cause of this? And just can you come in, please, Saksham? We'd like to hear from you. Yes, Saksham, please come in. Please come in. Please unmute yourself, and we can have a minute discussion on. You are right. This is electrical ordnance. So if you can come in and we talk about it for a minute.
Good evening, sir. Hello.
Yes, good evening. Good evening. Yeah, we can hear you, Saksham. Go ahead.
Sir, the QRS complex is one is bigger than the other one, which is known as electrical alterance. And is commonly seen in cardiac tamponade or sometimes in pericarditis.
Okay, very good. Very good point. Very well picked up.
Excellent.
So this is electrical alternance.
Thank you.
And is caused by the swinging of the heart inside a large pericardial effusion and can denote cardiac tamponade. Of course, cardiac tamponade is not diagnosed on ECG alone. The diagnosis is based upon especially the echo findings, which maybe if you have a case sometime we can talk about. We discussed pericarditis, if you remember, 2 sessions ago. Dr. Rajiv Verma might remember that we had a discussion on pericarditis, and that time we did talk about cardiac tamponade. But electrical alternance is the diagnosis. Go ahead, Dr. Seema.
Yeah. See, very good, Dr. Saksham. Electrical alternance, as you said, one complex is bigger, the other is smaller, alternately. But what is another thing is low voltage, and sinus tachycardia. If there is sinus tachycardia, it means there is compromise on the heart. So this is tamponade because of the sinus tachycardia, electrical alternance and low voltage. I would like to tell about low voltage here. How do you define low voltage in ECG? I think most of the people are aware that if you look at the limb leads 1, 2, 3, AVR, AVL and AVF, we take 5 millimeter of QRS length as the cutoff. So if it should be more than 5 millimeter normally, if it is less than 5 millimeter, then it is called low voltage, any complex, you know. And how we measure QRS, like I will show here, there is an R wave and then there is an S wave. It is low voltage. Below 5 millimeter in limb leads, it is low voltage. But what is the sensitive criteria where we can pick up more cases of low voltage? Now you remember 5 here. So take 1, 2, 3 and add 5 plus 5 plus 5. So if the QRS addition of 1 plus 2 plus 3 is less than 15, then it is low voltage. Similarly here, you take V1 plus V2 plus V3 and add 10 plus 10 plus 10. So if the V1 plus V2 plus V3 is less than 30, then it is low voltage. So by sensitivity criteria, it is definitely low voltage. By specificity also, except for this, maybe it is more than 10 millimeter, but otherwise it is mostly low voltage ECG. So combination of sinus tachycardia, low voltage and electrical alternance, that favors our pericardial tamponade. What is the differential diagnosis of electrical alternance? Electrical alternance can occur if the patient is severely dyspneic because of severe heart failure or because of asthma. And even asthma, low voltage, and even heart failure, low voltage, ECG, and everything can occur actually. But here the presentation was of atypical chest pain. So that favors more of cardiac tamponade. And then AVRT and AVNRT, but more in AVRT. AVRT also gives electrical alternance.
So one of the important ways to differentiate a narrow QRS tachycardia, whether this is a reentrant or this is a nodal reentrant or this is a pathway, is electrical alternance. This favors AV reentrant tachycardia rather than a common garden AV nodal re-entry
AV node.
tachycardia.
Yes.
Maybe relevant for cardiologists and electrophysiologists, but also a point, because otherwise you get a narrow QRS tachycardia. There are very few signs that tell you before you go in for a heart ablation procedure as to what you are looking for. Are you looking at AV nodal pathway, or are you looking at a pathway from the an AV pathway? So that, and also a small point, I have a, I'm fiend with the English language, so please excuse me. It is cardiac tamponade, not pericardial tamponade.
Okay. Yeah.
Okay. Pericardial effusion leading to cardiac tamponade.
I have tried to, make happy Americans and English both cardiac as well as pericardial.
So it's pericardial effusion. Pericardial effusion leading to cardiac tamponade. So.
Okay, sure.
One more thing I want to contribute, that the electrical alternance has nothing to do with pulsus alternance. These two are separate entities. Usually people confuse it that if the patient is having electrical alternance on ECG, there should be a pulsus alternance. It is not actually, but both are the signs of heart failure. And usually in heart failure, if there is an electrical alternance, if you see, you will find pulsus alternance, but it doesn't happen in cases of AV heart.
Very good point.
Yes,
excellent.
Wonderful. This is 25-year male,
okay,
found
next.
Collapsed on streets. Any takers for this? Should I go ahead?
Yeah, so we can see giant teal versions.
HOCM.
Yes, someone come in, please.
Yeah, HOCM.
HOCM. Okay.
Okay.
Good point. Why do you say HOCM? Why would you say HOCM?
Giant T-wave inversion.
Giant T-wave inversions. Okay. So for HOCM, you should have two things. One is this kind of T-wave inversions in HOCM is seen in the apical variant of HOCM and mostly seen in the lateral chest leads. Here they are seen in all the chest leads. And secondly, you are likely to have criteria of left ventricular hypertrophy along with these kind of T-wave inversions. So I think it's a good differential diagnosis, but these could be the points that might be against it. So we don't have any features of LA enlargement. We don't have any features of significant widening of the QRS, and we don't have any other features of left ventricular enlargement by any voltage criteria. So we have again, yes. So we have Dr. Alpana saying intracranial bleed and Dr. Saksham saying Brugada syndrome. So Brugada syndrome is, would you like to talk about Brugada syndrome? How the ECG changes?
In Brugada, there is usually associated ST elevation. And this typical T-wave inversion is called waterfall sign. And it is seen usually in association with intracranial pathologies, usually subarachnoid or subdural hemorrhages. Sometimes happens with large hemorrhagic intraparenchymal hemorrhages also.
Very good. So Brugada, the classical Brugada syndrome is a SC elevation or J point elevation one along with T inversion, and which is not seen at all. There are other variants of Brugada also, but this is the classical. In V1, you should find this kind of ST elevation followed by T inversion. So I think Dr. Alpana Chug has nailed it along with Dr. Satbir. Am I right, Dr. Seema?
Perfect. See, I am coming to that HOCM thing. The T waves are really very broad based here. So they are giant, but so broad. Everywhere it is broad, and there's a very much prolonged QT. So HOCM, we don't see prolonged QT. Secondly, HOCM will have a tall R wave in V1, because of the septal hypertrophy, the forces are directed towards right. And you will have a dagger Q waves. I mean, because of the subaortic gradient, you will have really tall R wave with Q wave also in one AVL. But long QT and such broadening of the T wave is very classic of intracranial bleed, and patient has presented with collapse. So This is a sign
so
of,
in all fairness to someone who said anterolateral ischemia, sometimes
yes.
when we have patients in the evolving or recovering stage from myocardial infarction, you might come across these kind of very giant T-wave inversions. Usually they do not have much implication and they gradually progress and become normalized. So that could be a point in an evolved or a series of progression of the acute MI changes during the recovery stage.
Can we get in, sir, post cardiac arrest patient also such changes?
Yes, we do get in post-cardiac arrest patients also. Again, the implication is we are not certain what the implication is, whether this implies ischemia or not. So most post-cardiac, early post-cardiac CPR resuscitation ECGs, we are not able to draw any conclusion as to what might be the pathology. But this can be a feature of post-cardiac arrest.
Post cardiac arrest, post CPR revival, we have seen these patients, particularly in patients with hypoxic injury to the brain. And again, the same intracranial thing.
Right. So please
So
reveal the diagnosis and your
the
discussion.
diagnosis is the same. So the giant T-wave inversion with long QT. Please keep long QT also in mind. And so this is a sign of raised intracranial pressure. Could be because of massive hemorrhage, as the other speaker said, intracerebral or subarachnoid. And it could be because of ischemia also, but then ischemia has to be very large to cause the edema around and increase the brain pressure. Now this is 75-year male and presented with sudden collapse while shopping with wife. Now I will tell you, I will give just a clue. This you see in inferior leads. This is a sign. This is some appearance. There is a term for it. Can anybody tell me what is that term?
Is it coved ST?
Yeah, but what is the term for this whole appearance of this complex? And what is the diagnosis, of course?
Very good. So I think we have got very, very bright attendees. I'm so impressed with the quality of the attendees that we have today. So it is an acute MI. Dr. Rajiv, you are right. This is ST elevation, but there are certain terms. So there are two terms given. Dr. Ramya is saying this is the tombstone sign, and Dr.
Yes.
Alpana is saying this is the shark fin sign. But
Absolutely.
I think clearly, whatever sign you might want to call it, whatever sign you might want to call it, clearly you must say that this is gross ST elevation in the inferior leads, along with ST depression in the anterior leads. So whenever you get this kind of a situation, ST elevation and ST depression, make the diagnosis of the territory which has the ST elevation, not which has the ST depression. All right. So this is a patient experiencing a massive inferior MI, and this is known as the shark fin or the tombstone sign. And you should not miss the ischemia based upon what this feature is, as well as the reciprocal changes seen in the anterior leads. Am I right, Dr. Seema?
Perfect, sir. And can you appreciate the right
And
axis here? Yeah, this is actually lateral wall also involved. And can you appreciate in V3, there is a sudden tall R wave with more ST depression. So probably posterior is also gone. So there is a acute infra-posterolateral MI. And because of the lateral, there is a right axis deviation. And of course, you can see the reciprocal ST depression. Now I would like to show you shark fin. This is how it looks. And see, this is how it looks. This is whole ST actually. The QRS is all engulfed in the ST segment. And this is a junctional rhythm. You don't see P waves here. So this is acute MI. And now this patient was thought as hyperkalemia. So cath lab was activated late. And when cath was done, because of when the patient did not respond to the treatment of hyperkalemia and potassium came out to be normal, it showed 100% RCA block, but patient had cardiac arrest again and patient could not be revived because of this delay in the interim. So this whole, appearance, tomb appearance is that it carries a poor prognosis. because there is so much of electrical and hemodynamic instability and so much large chunk of myocardium is involved in this.
Right, right. Is that your last slide? I think.
Yes, thank you very much,
yes.
sir. Thanks.
Yes. Yeah. So thanks, Seema. Excellent slides. I think everyone will all
Thank you, sir.
agree that really interesting, and thanks for all the effort that you made and provoked a good thought process, got our cells working. You know, ECG is a dicey thing for everybody. You know, it's like no one is 100% confident of every ECG. I've seen the topmost electrophysiological experts disagreeing on the ECG findings.
Yes.
And I think every time we see an ECG, it's a learning. So thanks a lot for that. And we now have just a couple more ECGs presented by my colleague. If you have, we have 10 more minutes. We'll try to wrap in time. So if we can start.
Dr. Seema, if you could just stop sharing your screen. Thank you so much.
Should I share my screen, Prashant?
Yes, sir. Please go ahead.
So Dr. Seema has already told that how much traumatic can shopping be of a wife when husband is along with that. So the ECG was looking like a typical credit. So we will discuss the ECG now again. This time it was not shopping related, but definitely chest pain, and patient was having diabetes and hypertension, and 65-year male, strong family history of coronary artery disease. So this is the ECG. No tachycardia, no ST elevation, no significant ST depression if you think, and no T wave inversion. So any suggestions from the audience?
Sorry. Yes, so someone would like to take up this ECG. All our bright attendees, I think the answer should be quite easy if you look at lead 3. If you look at lead V2 and V3, maybe that will give an idea as to what.
So, एक minute नहीं अपना तक है. So actually I received a call from Dr. Rai saying that, you know, the education thing has gone pretty well. So you
Hello,
should be,
who's speaking? Sorry.
Sorry about that. Please continue.
Yeah, all right.
So should I say?
Yes, yes, of course. Now you're on the other side.
Posterior MI, it looks like.
Why do you say posterior MI? Let Dr. Ramya tell us. Dr. Ramya, I think Dr. Seema has spoken enough, and we know now you're an ECG
Yeah, that's
expert.
what I asked you.
So we'll send all our difficult ECGs to you. Yeah. So Dr. Ramya, would you like to discuss this ECG?
Sir, the ECG is showing upright R waves in V2, V3, V4 with suggestion of ST depression in the same leads. Without any other, remaining leads are almost normal. So this is looking like posterior wall MI, sir. Isolated posterior wall MI.
So this is an ECG of true posterior MI. And true posterior MI, if you see that it is to be seen from the posterior side of the ECG also. And if we reverse the ECG paper, if we reverse the ECG paper and see from the back side, you can see the typical signs of ST elevation, that is Q wave, ST elevation, and T wave. This is the reverse side of that ECG paper. So if you suspect posterior MI, see from the posterior side of the ECG paper. That is the message from this particular ECG. As Dr. Ramya has already told, that R more than S in V2, prominent upright T wave with ST depression. These are the signs of true posterior MI. And it is very important to find out true posterior MI, because the complications of true posterior MI sometimes can lead to a condition which is not repairable, like the rupture of chordae, like ventricular aneurysm, sudden cardiac death, and the rupture of septum in case ventricular septal rupture. And one may not get the clue that patient was having chest pain, and another fine day had cardiogenic shock, and and there is a lot of tachycardia. Then the echo become unremarkable. You don't find it anything on the echo with tachycardia. You try to miss out things because the patient become breathless. So it is very important to diagnose true posterior MI, and usually true posterior MI happens in patients with large circumflex, which can be either thrombolized well in time, or one can do angioplasty. So these are the three MIs which one should really think about. These are the three MIs which you only see on ECG, only then you can find them. That is the true posterior MI, RV MI, and high lateral MI. RV MI means that ST elevation is V3R, V4R, and sometimes with V1 lead. And the high lateral MI means ST elevation in L1 AVL, usually happens because of the large ramus intermedius or large OM1. So these three MIs one should always try to look into, that is the true posterior MI, RV MI, and high lateral MI. Otherwise, one is bound to miss these MIs on routine ECG lookup. And these two things which one should overlook in all the ECGs, that is the T wave inversion in V1, V2 in females, which happens in almost 25 to 30% of the females, and isolated T wave inversion in lead 3. These two, sometimes it happens that patient comes to us with a chest discomfort, and there is an only isolated T wave inversion in lead 3. And we think that it is, there is a STT changes, T wave inversion. It could be unstable angina, but isolated T wave inversion in limb lead 3 is normal. So one should overlook these two findings, and one should always try to look for posterior MI, RV MI, and high level MI. So this was the message from this particular ECG. So the next ECG is this patient. Again, ST elevation, very much similar type of changes that of ST elevation MI, and this patient presented to us in the hospital with fever and this particular ECG. Any comments from the audience?
Quite often we are called to the ICUs, and we find that the patient is suffering from, patient is in shock, has got severe sepsis, and with multiple other issues, and we are called to look for an ECG, and this is what the ECG looks like. So now we are always in a dilemma: is this an MI? Should we take this person into the cath lab? Is this patient actually a case of cardiogenic shock which is missed? So many issues come up, you know. So would anyone like to comment or like to say something about this? So we're going to be discussing now what is a very important entity, and this is the last slide and last thing that we're going to discuss. I think Dr. Sabhi, why don't you reveal the diagnosis?
So in this particular patient, keeping the diagnosis of ST elevation, though there are some points which are against ST elevation in this particular ECG, that there is no territorial thing in this. Usually MI has a something like that it is either lateral or anterior or posterior or inferior MI. Here the ST elevation, if you see, it is in the L2, L3 AVF. It's in the V2 to V6 in all the leads, and there is no reciprocal changes, which usually we see in acute coronary syndrome in any form, in most of the times in ST elevation MI. So, but still, because the patient was in shock, and still there is a possibility that patient can have triple vessel disease with ST elevation MI, can have ST elevation in multiple leads, which cannot explain any territory. This patient underwent angiography, which revealed normal coronaries. And then after that, we did LV angio of this particular patient. You see that in this particular LV angio, there is the bases of the left ventricles are contracting well, and the apex and apical segments are not contracting at all. They are like ballooned out. This particular condition is called apical ballooning syndrome or sarcosubocardiomyopathy. Sakosubo is vessel used by Japanese to capture octopus in the sea, and the shape of the heart has turned into like a Sakosubo vessel. The T's are silent. Again, the problem with the English language that they write T and they don't spell it. Sakosubo cardiomyopathy, and this particular type of situation is usually because of increased catecholamine levels because of stress. This stress can be because of sepsis. These can be because of the large CVA also, and these stresses can sometimes be like Dr. Seema's case, shopping with wife also, and that can happen also. And sometimes I also feel palpitation while going on shopping with my wife. So that is the thing that one should be very much aware of the situation that this particular condition, that if the ST elevation is there and you don't find any territorial type of thing that this particular ST elevation is in one particular territory, then one should think of Sakosubo cardiomyopathy. And the important point is that because this is a catecholinergic, because of the high levels of catecholamines, that if we start these patients on inotropes, usually these patients they worsen on inotropes because they are again catecholamines, and the treatment of choice is intra-aortic balloon pump, which will support the heart, or at the best is ECMO to support these patients.
So excellent points. I think Dr. Sadhbir has shown us very important ECGs that we should not miss. And some of these MIs, if you do an echo, you might not find anything. So unless you look carefully at the ECGs, you will miss them. And also, Sakosubo is a very, very more common thing that we are seeing, especially in our medical ICUs. We get called in quite often. And we find that the echo has been done. It shows that the ejection fraction 25%, patient is in shock. Quite often these people land up in the cath lab along with to do an angiogram, which is normal, and that only worsens their condition. So this is actually a real interesting and important problem. And I think we can devote actually an entire echo session to, these kind of acute cardiomyopathies with actually normal coronaries and how we can look at them. But very important lessons to be learned. So I think you finished,
Yeah.
Doctor. So we finished our presentation, and I think we are at a good time to also conclude the session. Would anyone like to make any closing comments, or if anyone would like to say something about the presentation, or would like any comments are welcome before we close. And I'm going to hand over to Prashant also regarding the final few minutes.
Dr. Balla,
So I'd like to say, if you enjoyed the, yes.
Dr. Balla, I want your experience in cases when the QT prolongation is there in hydroxychloroquine and azithromycin used. So there was a study in international journal that 22,500 cases, there was no torsades. So what is your view and experience with using hydroxychloroquine alone or in combination? In COVID, because
I'll give you yes. So very important, observation in these times, very pertinent. As cardiologists, we are very worried about prolonged QT, because prolonged QT can lead us to torsades and very, poor outcome in these patients. And combining two drugs which have got a potential for prolonging the QT makes us even more suspicious, especially as none of these drugs have got a curative function in treating the SARS-CoV-2 virus.
Right.
My personal take as a cardiologist would be that if I am to expose patients to these, especially those who are elderly, those who have got other comorbidities and who are on other drugs, other cardiac drugs or other drugs, will be to very carefully monitor their QT. I'm not aware of the study that you're saying, and if there's no evidence of torsades, it's a very reassuring finding. But I would still be carefully monitoring these patients' QT, and if it is prolonging more than 500 milliseconds, I will withdraw one, if not both. these drugs?
Actually, we had been using hydroxychloroquine in basically rheumatoid arthritis for quite long, up to 6 milligram per kg, and there is no side effect seen.
I agree with you. I agree with you. I agree with you. We, in fact, before this, for patients on rheumatoid, we were hardly monitoring them, and almost no patient came back to us with any problem. But since it has been highlighted, and now if we are combining with other QT prolonging drugs, we should be careful to monitor the QT at least. I think that is being sensible.
Thank you.
Right. So, if everyone has, okay, so there's a question, right? Why is there no tachycardia despite of elevated catecholamine levels? All right. Raised ICT in this patient of yours, no raised ICT as bradycardia with anterior wall elevated. I mean, why no tachycardia in spite of raised catecholamine level in your ECG?
In cases of Takotsubo, patient might be on beta blocker, multiple reasons of tachycardia. Takotsubo cardiomyopathy can happen in intracranial hemorrhage, and intracranial hemorrhage causes bradycardia, which can compensate for the tachycardia of the sympathetic drive. So that can happen.
I agree, quite likely, quite likely. So there can be many reasons. If there is sepsis associated cardiomyopathy or Takotsubo or other stress, it can lead to tachycardia. But if there is, if this Takotsubo is occurring because severe intracranial stress or hemorrhage, it may not lead to tachycardia. All right. So if there are no other questions or queries, we'd like to thank everyone for attending. We'd like to keep you all informed that we are doing these cardiac echo teaching and learning sessions once in 2 weeks. It is going to be now case-based. We are going to upload a form to you. Whoever wants to send a case or problem to be discussed, please use that form. It will be sent across to your emails or uploaded in the group. And as you can see, it's a nice friendly way to sort out problems and issues. We'll be very happy to discuss. So please upload clinical situations that you would like to be discussed. We'll be happy to. So before I end, I'd like to hand over to Prashant, who's from ECHO India, to conduct the closing minutes of the session.
Question. Can I ask? May I just compliment you and say thank you? Excellent session.
Thanks a lot, Dr.
I'm Sunil Kohli, Dr. Bhalar, Sunil Kohli.
Yes, sir. Thanks. Thank you so much for attending. I'm so glad you enjoyed.
I enjoyed every bit of it.
Please, we look forward to you and more from your team joining us in future sessions. Thank you. Yes, over to you, Prashant.
Dr. Shubham Vasudeva had a question.
Hello, sir, I want to ask a question.
Go ahead, Shubham.
Sir, can you please explain what is, like we had a patient, he was in a septic shock and we resuscitated him, fluids and everything, normal cardiac function. Before his onset of sepsis, the ejection fraction was 60%, no history of CAD. And after resuscitation, we had the BNP levels of around 4,800. So does that carry any significance in a cardiac point of view?
So BNP is very sensitive, but not very specific. It can be raised in various clinical scenarios, including sepsis, CKD, anemia, and so many situations, pregnancy, it can be raised. So unless you have got a situation where there is a decrease in the LV function, in this acute setting, it cannot be used as a marker for heart failure.
Okay, sir.
We find quite often in all the ICUs now, every patient's troponin and BNP is sent, and we are finding it is non-specifically raised in many situations. Troponin might have some prognostic significance, but BNP does not have prognostic significance, and it is diagnostic when you have a clinical situation of volume overload with or without reduced LV function. Will you agree?
Yes, during resuscitation, we usually give DC cardioversion to the patients, and we are passing high voltage electrical current through the myocardium. So that could raise BNP because of the myocardial stress. So post CPR, BNP, raised BNP, I think is of a doubtful significance.
So in this case,
Does that answer your question?
in this case, we should
Yes. Yes. Go ahead. Please go ahead.
treatment of septic shock rather than converting it to for cardiogenic shock and other things like we should think it on the point of sepsis only and no need of cardiac intervention in any case.
Yes, you must go as per the clinical scenario and of the patient and what that is telling you. So unless there are significant ECG changes, unless there is gross changes on the echo, do not presume that this is a cardiogenic shock, but treat for septic shock. And these are incidental findings.
Okay. Thank you, sir.
Okay.
Okay, Dr.
Yes,
Bhatt.
Prashant, please.
So, without taking much of your time, I would like to thank everyone who had joined us today, and thank you again for making this such a interactive session. I would like to share a small feedback form. I would kindly request everyone to stay back for a couple more minutes to share your feedback with us. This feedback form should be visible on your screen. So your feedback is very important to us. It will help us improve the overall quality of the sessions and will also help us keeping in mind about your needs as well. Thank you so much for joining in today.
How to poll it actually? The thing is highlighted here.
Yes, so you will have to select the options and then scroll down.
It's not being selected.
Scroll down for the rest of the questions, and then you'll get an option which says submit.
How to select it? It's not getting selected. I don't know. I'm not able to do it.
Okay, so we will take that into consideration. We'll share this form with you once the session is over. As part on the you're in the WhatsApp group. Dr. Bhala, is that correct? Is everyone on the WhatsApp group that we have? Dr. Bhala, I cannot hear you. You are muted, I guess. Yeah.
Everyone is on the WhatsApp group. I think most of the people are on the WhatsApp.
Right. So we'll create a form and we'll send it across to you for your feedback. You can also use that. For all those who are able to access the form right here, could share their feedback with us. For the rest of them, we'll share the feedback on the WhatsApp group.
Okay, very good, very good. So kindly fill up the form and just so that we're able to do this better.
Thank you everyone for sharing the feedback with us. we'll reach out with the details for the upcoming session with you on the WhatsApp group, or we'll make it a habit of sending out emails as well from the next session onwards. Thank you so much for joining us today.